Hello, good morning class. I am Professor Streb. I will be going over your Unit 1 assignment, the reading assignment this week. It'll be care of the patient with common alterations in tissue integrity, health and wellness, safety, skin assessment, and immobility. If you go to your syllabus, you will see these exact subheadings on the left-hand side under Unit 1, where it's going to discuss health and wellness, safety, the assessment of skin, and then talk about common alterations in tissue integrity with patients who have dryness, pruritus, urticaria, trauma phases like pressure ulcers, common inflammation things, psoriasis, skin cancer, cellulitis, nail disorders, herpes zoster, and immobility. The page numbers are listed for your book in the 10th edition, and you can read those specifically to see what it is you need to focus on in order to get all you need out of this chapter. Health and wellness is a very broad topic, and I get that. But NCLEX focuses a lot on health and wellness. Between that and safety, it's going to be very heavy on your standardized exams throughout nursing school, as well as on ATI and NCLEX. You're not going to get away from this. The nurse's job is to help improve the health and prevent future illnesses by teaching your clients about a lot of different stuff. How to eat healthy, how to manage their diet, how to exercise correctly. It's not good enough just to say, oh yeah, eat better and exercise. How long should you exercise? How much should you eat? What is a dietary restriction as far as milligrams of sodium? Things of that nature. What kind of foods should you be eating if you're trying to heal a wound? You think about foods that are high in protein, because protein we know is the one thing that helps rebuild tissue. So if somebody has a big ulcer, pressure ulcer somewhere, we're going to look at their prealbumin levels to ensure that their total protein levels are high enough to heal the wound, if you will. So we really have to look at what it means to be healthy and what wellness is. Physical activity. We know that regular activity will improve your healthy lifestyle, but most people aren't getting that 30 to 40 minutes a day, 3 to 4 days a week. It's just something they don't get. And another thing that's going to be very, very particular or very important to you throughout this program is understanding exercise and diabetes and heart disease and how they all kind of marry together. We'll talk about that as we progress throughout the chapters and get into these more advanced type topics. When we get into the endocrine system and start looking at diabetes, when we get into heart disease in week 9, we'll start looking at how exercise and nutrition kind of play a part in that as well. All right, safety is huge. You're going to have to understand safety because safety is the focus of much of what we do in nursing. Your book lists a lot. I'm trying to break it down for you here so you can kind of get an idea of what it is you need to look into. So you're going to have to understand how to teach your patients about the use of a cane or a walker or any other kind of ambulatory device. How do you ambulate with it? When you're going up and down the stairs, how would you use that? Which leg goes first forward? Which hand goes first forward? I know these are things you've heard of. You're all LVNs, so it's nothing new to you. However, you have to know specifics in order to do well with this, right? Keeping the room free of clutter. We know this. You need to have adequate lighting. Adequate lighting does not mean you leave the lights on at night. You can't leave all the house lights on or the patient won't sleep correctly. Start thinking about patients who are at risk for falls. If you identify any patients with recent falls, that puts them at high risk for falls. If your patient is using a diuretic is going to make them get out of bed and go pee more often, right? So the more often they get out of bed to use the restroom, the more likely they are to have a fall. So these are some of the safety concerns. You got to think outside the box. We're not going to ask you, questions that are memorization. They're going to be, which of the following patients is at greatest risk for falls? This is what we're talking about. The people who have risk factors that make them likely to fall. And then when you know that, use things like a gait belt to assist your patients. When you have a patient who is sitting on the edge of the bed, make them dangle their feet first, right? If a patient is on a diuretic or they're on something for antihypertensive medications, we know it's going to cause some hypotension. So orthostatically speaking, when they sit up out of the bed, it's very possible that orthostatic hypotension takes over. And if they get right up, they could fall because their blood pressure bottoms out. So this is the type of safety stuff you're really going to have to pay attention to. I'm just going through things that make sense to me. When you have a patient who's moving slowly, or if they can't ambulate on their own, out there using the walker, keep the walker as close to the body as possible. We're going to talk about this in the lab over the next couple of weeks as we kind of talk about safety and mobility. Always looking for pain, complaints of shortness of breath when they ambulate. Anything that would make you suspect they might fall. If you're in pain, are you really going to adequately ambulate? Or might you stop and be lazy in your efforts because it hurts? If you can't breathe as you're walking, are you going to try to rush through it? These things, they predispose your patients to some safety issues. So those are the things you have to really kind of pay attention to. I think about when you have a patient who's walking with a cane, make sure that we move the cane and the weaker leg together and then the stronger leg. That way they always have those 2 points on the ground that prevents them from falling one way or the other. And you as a nurse, you also have to think about your own safety. We know that ergonomics and back injuries are the leading cause of nurses for leaving the profession. So you need to make sure that when you're lifting the patient, you're not doing it incorrectly. Safe body mechanics, correct posture, keeping your feet slightly apart to give you that wide base of support. Make sure you're using things like a Hoya lift instead of using your own back to do this. These are things that you have to pay attention to, right? And then teaching, you have to be able to teach your patients. You have to make sure that they understand what is safety, as well as your people you're delegating to. You're going to be a registered nurse when you delegate to the LVN and the CNA or the UAPs. It's important that they understand that when they lift somebody, how would you observe if somebody's doing it correctly? So you might get a test question that asks something like that. Which of the following actions by the newly hired nurse would indicate the need for further education on the chart nurse's part? Something like that. And, it's keeping your body position where the patient's as close to you as possible. You're not reaching out far. That's how you injure your back. So keep these things in mind as you're going through safety. Skin assessment. The integumentary system is something we look at every single time we walk into a patient's room, right? We assess the patient's skin and their circulation all the time. Anytime you look at somebody, if they have pallor or they have cyanosis around their lips or if they're beet red, that's a skin assessment. And also with skin, we know that circulatory alterations play a huge role in the way your patient's skin presents. So, every 8 hours at a minimum, we need to be looking for signs of redness, tissue ischemia, especially over anything that has a bony prominence, shoulders, sacrum, the scapula, hips, heels, ankles, toes, you name it. We have to be very aware of people in their skin, because integumentary system skin breakdowns can lead to increased length of stay and poor patient outcomes. So you need to really be aware of what it looks like when you're dealing with patients, right? We know that there are different shades of skin. We all have different skin tones. That goes without saying. Nobody in the world is exactly the same, so we're all different colors and we're all different genetic makeups. But we know when we're looking for the cyanosis and signs of that gray colors around the lips and tongues, it's easier to tell when there's a blue tinge when we look at the palms and soles of the feet, like I said, around the lips, the tongue, the mucosa areas, especially in clients who have darker skin or more pigmentation. Reposition your patients. Often, one of the biggest causes of skin breakdown, of course, is immobility. If your patient can't move actively, then passively, you and I must go in there and do that. If they're sitting in a wheelchair, be aware of where their pressure points are. Of course, the sacrum is going to be there, but also the elbows. So we're going to teach our patient to raise themselves up off the wheelchair, for as long as they can. Usually about 10 seconds. About once an hour, they should get up and move. It's no different than somebody who's sitting around and we're trying to prevent DVTs. We want them to move their legs and move around at least every hour to get blood circulation. So when we raise them up off the chair, that gives a little bit of blood flow to that area. Kind of what we're going with. And another thing, how do we reduction of pressure? We could put pillows or other type of soft devices underneath a bony prominence and a hard surface, just like the bed. The bed could be a hard surface. Sometimes we put high top tennis shoes on our patients to prevent that foot drop. When they're immobile, it kind of keeps the foot from doing that plantar flexion. We kind of keep them in a dorsal flexion. But when you put a high top tennis shoe on somebody, it still creates pressure around those areas. So you're going to have to relieve the pressure that the tennis shoe creates as well. every couple hours. So it's an ongoing process. What we do in nursing doesn't stop. It's continual. So you have to be out there always assessing your patient, always looking for new changes and new signs and symptoms associated with an issue, and then think about what your job as a nurse is. Your nursing interventions are what we're going to test you over. Can you identify a problem, a patient who has a problem or a patient in need based on their assessment findings, which includes labs and x-rays and everything else, what they say, what you hear, what you see, vital signs, all of that. Even their family history or history of other diseases put them at risk for things. So all of that assessment data is going to be the first part of how we're going to, test your knowledge. The second part will be, what do you as a nurse do? That's really what we're going to ask you. What is the nurse's role, basically? Think about, we'll go through this in a minute, but there's only certain things you can do. Let's go to the next slide and look at this. So when we're caring for patients who have alterations in tissue integrity, we think about dryness and pruritus and urticaria and things of that nature. We're not going to do a lot to treat the underlying disease. That's not our job. That's the doctor's job or the advanced practice nurse or the PA. They diagnose and treat because they have an NPI number. You and I as nurses don't. So we treat the signs and symptoms associated with the disease process. That's why we use nursing diagnosis, right? Alteration in tissue integrity. That would be dryness, right? We can do something about that. So we can think about people who are older and kind of what they have going on makes them more at risk for skin breakdown or dryness. Pruritus, there's a lot of different disease processes we're going to get into, especially when we start thinking about patients who are in kidney failure or if they have too much uric acid buildup. They get really itchy and they'll scratch themselves. Psoriasis, eczema, keeping fingernails short is something you and I as nurses can teach and do for our patients to prevent causing more skin breakdown. It's the little things in life that are going to give us the biggest bang for our buck as nurses here. Pressure ulcers, I'm not going to have you stage ulcers. That's not what we're doing in this class. However, it is important to understand when there's a problem. Non-blanchable or erythema, yeah, that's a stage 1. Stage 4, you know what a stage 4 is. You can see right in, you can see the fascia, you can see the muscle and tendons. In between the two, there's stage 2 and 3. Like I said, you and I aren't going to focus on that a whole lot because it's not what we do. What we are going to focus on is the wound management itself, right? So one of the biggest things we're going to do when you're looking at a client who might have a pressure ulcer anywhere on their sacrum, on their heel, on their elbows, on their shoulder, you're going to have to perform some checks to make sure they're okay. So you're going to do neurovascular assessments to make sure that there's no involvement of the nervous system, like it went really bad. You're also going to have to determine the size, the color, the extent of tissue involvement. It doesn't mean I need you to stage it. Like I said, I'm not going to ask you, is it a stage 1, 2, 3, or 4? It's not what I'm going to ask you to do. But you do need to have an understanding of kind of what it is. Because we know what it's stage 1. All we're going to have to do is reposition. Stage 2, alleviate the pressure. Put some kind of barrier down if you can. Stage 3 is when we have to get into like dressing changes, the wet to dry dressings and things like that. Look at wound vacs and how they need to be monitored every few hours. Dressing changes every 2 to 3 days. Antibiotic type therapy. So it's the changes in the treatment outcomes is what we're looking at. And then when you get like a stage 4, same as stage 3 basically, but they might need to consider surgery. So those are outside of your scope of practice, right? And we're not going to do the surgery and stuff, but we know what we need to monitor for. We know that we need to debride. So that's kind of where your mind needs to get, right? And we know that your job as a nurse, if you're caring for a patient who is post-operative from having one of these wounds debrided, right, at like a stage 4, when they come back, you have to monitor them for what? Well, fevers and signs and symptoms of infection. Those are going to be very big. If you notice a patient who comes back post-operative from one of these type of clean-out surgeries, one of the first things the nurse is going to have to do is swab and culture it, right? So typically we clean around it. We don't clean the wound itself, but we want to get any kind of surface bacteria away. And then we want to swab that wound for a culture and send it off. So if there is any kind of infection, we'll start working on a specific so we can get the use of a non-broad spectrum antibiotic and one that actually focuses on repairing or fixing whatever virus or bacteria, whatever bacteria is there present, so we can treat that with an antibiotic. So don't forget that. That's part of your role. A big part of wound management, like I stated earlier, is nutrition. Y'all, we're not healing wounds if we're not being nutritionally aware of what our patients are taking. So dietary consults are something that's going to be very big for you to do. You can request for a consult. I'm not saying you're looking for a consult from a cardiologist. We're saying that you can call dietary and say, hey, I need you to come evaluate my patient who has a wound healing and see what kind of diet would be best for them. Then they will work with the doctor and figure that out. So ask them. They'll give you that dietary consult for recommendations. And be sure that you're paying attention to their total prealbumin levels, because prealbumin levels will always give you the best indicator of total protein in the body. And we know that protein is how we heal these kind of wounds. So this is what you have to do. Make sure that you're really paying attention to these patients, especially ones with chronic wounds. Sometimes they're going to receive that negative pressure wound therapy. And if they do, they're going to have to follow up with their PCP a lot more than some of the other patients. All right, kind of moving along, psoriasis. This is a disease. It's a specific disease, right? We know it's an overproliferation of the skin cells. It's usually autoimmune. But what are you going to do for it as a nurse? You're not. You're not going to treat it. That's not your job. What your job is to ensure that when you're providing teaching to the client, that they understand what needs to happen, right? What do they need to do in order to manage their symptoms better? So they need to understand that if they have a fever, if they start increasing the fever after taking their medications, we know that some medications are going to decrease their immune system even further. I think about like Humira. Phil Mickelson's a golfer, he was on that, but we know with those type of biological agents, it decreases your immune system. So if you get a fever, that's something that your patient needs to be aware of is, hey, let me go ahead and call my physician for this. If they're on antibiotics, those can trigger the plaque lesion formations. Make sure that the patient understands that they need to put the steroid creams on the skin to decrease inflammation. They should wear the light, loose cotton clothing that doesn't cause any extra trauma to that area. Don't scratch them. Monitor the skin daily. Warmer climates like San Antonio with this humid air a little bit and exposure to sunlight, we know that that type of radiation from the sun, so sunlight, UV light, helps slow the plaque development down. And then another part is maintaining a healthy body weight, because obesity can make it more, your psoriasis a little more aggressive in the overproliferation of the cells. It's an inflammatory disease. So when you're overweight, it does cause some inflammation as well. So these are the things you need to talk to about your patient. When you're reading your book, you might not consider any of this. I'm skipping over the other stuff because this is really where I need us to be when you're thinking about what your job is. Skin cancer, this is another skin ailment. Are you going to treat skin cancer? No, because you can't. The only person who can treat skin cancer is the physician, right? They are the ones who are going to diagnose and treat, and they're either going to do some kind of removal through surgery of the cancerous item, they're going to do chemotherapy or radiation. That's what they do. So what is your job as a nurse? Your job is going to be really the teaching aspect. Talk to your patient about applying that SPF 30 sunscreen every 30 minutes before going outside. Wear that protective clothing to keep the sun off of their skin. Stay out of the sun during peak hours. Some states it's 10 to 4 o'clock. Y'all know San Antonio, it's like noon to 5 o'clock at night. So it just kind of depends on where you're at. Just be aware of what you can teach your patient. Ensure that they keep a body map, right? So they know where there are scars and lesions. That way they can detect those changes. That is where we are going to be more productive in our fight against skin cancer and deaths from skin cancers, is by talking to our patients about this, encouraging them to do their monthly self-skin exams, right along with their breast exams or their testicular exams. It just depends on what you're talking to. So these are the things you need to focus on. The rest of it is somebody else's job. Cellulitis, one of my favorite terms that we use in medicine because it's just an inflammation of cells. It's not a specific disease, really. It's just saying, oh, look, your cells are inflamed. That could be anything. So you're going to take care of lots of patients who have cellulitis. In our area here, we see a lot of cellulitis in the lower legs because we have a lot of people who have diabetes and peripheral vascular disease. And so they have a poor venous return due to hypertension and diabetes. So understand what signs and symptoms that you would expect to see in a patient who has cellulitis. I mean, they're listed here on the thing: inflammation, that redness, the erythema, feverish, warm skin, swollen lymph nodes. All of those can be as signs and symptoms of some kind of inflammatory process in the cells in those areas. What puts you at risk factor for this? I kind of said it a little bit: obesity, diabetes, mellitus, heart disease, so poor circulation, right, and hypertension. If you have some kind of lymphedema in your leg, you have a lymphatic problem, or any other kind of damaged skin, that can also put you at increased risk for cellulitis, because now you have an open break in the skin, and we can get bacteria that kind of get in there and take over. Treatments and therapies are based on what the doctor says. Usually it's some kind of oral antibiotic or some IV antibiotic. We will elevate affected areas to help drain the legs to promote venous return. Try to prevent any kind of pressure ulcers and further damage. It's kind of what we do. And then, if we need anything else, we'll just, see what the doctor has to say. Your book also mentions nail disorders. So fungal infections of the fingernails and toenails are typically the ones we end up seeing. They thrive very well in these warm, dark, moist environments, right? So older adults who wear shoes all day, who can't get down there and change their socks or do things like that, they very well might have more chances and be more susceptible to fungal infections. People who are immunocompromised, if you have lupus or if you have cancer or HIV or anything else that might make you immunocompromised, or you're on long-term steroids, so like prednisone, that can definitely lend itself to you being more susceptible to these nail infections. And people, if you have the artificial nails, that is a warm, dark, moist environment where you can get all kinds of stuff in there. So assessment findings, depending on what you're looking at, but you might see those thick, yellowed, and friable nails that are very brittle. I see that in a lot of my older patients when you take their shoes off. They might be painful. Like it just all depends. Your fingers can be crooked. Your nails could be clubbing, caused by a lack of oxygen. So a lot of different things you need to worry about. But the main focus is just patient education. Make sure they don't go barefoot. Avoid damaging the skin around the nails, so don't cut them unless you go to somebody who's more professional, especially when we're talking about diabetics. And do what your doctor says. You can do those things, you're probably going to be okay. All right, last disease I'm going to talk about is herpes zoster. When we think about herpes zoster, I want you to think about chickenpox or varicella or, shingles. They kind of all go in that same realm together. They're not the same, don't get me wrong, but skin disorders that develop after an infection with varicella can be problematic. So what do? We have to think about what happens. So a lot of people will have an acute reactivation of the varicella zoster virus. That's where shingles come from. So if you had chickenpox as a kid, it lays dormant for a long time in that nerve root. And then one day, bam, it pops up, and there you go. You start ending up with these painful lesions that are typically around the nerve ends, on your back, things of that nature. I think about herpes zoster as well, not herpes zoster itself, but if you think about, a simple, like a cold sore, that's still in the herpes spectrum. And I say this because if you've ever seen or felt that, it kind of goes on that same nerve ending around your lips or your face. So you can kind of make a connection on what that looks like. They're contagious until the lesions crust over and fall off, and then you're kind of good, for there. But for you as a nurse, you're going to be assessing the client who has the diagnosis of a herpes zoster. And then you're going to have to make sure you understand what it looks like. And it's usually going to be some kind of painful vesicle that, like I said, is it's painful, its skin erupts, it can be fluid filled, and then once it starts to crust over and fall off, then the contagious time is gone. They treat that with cyclovir. It's an oral medication. Corticosteroids can help decrease inflammation. Some kind of anti-itching creams and anti-pain, like some kind of analgesics, can work as well. We're not going to talk about it right this second, but we'll talk about it later on, and that is precaution types. A patient with herpes zoster is going to be placed on airborne precautions. I know that sounds weird, but airborne precautions are anything that can be transmitted through the air, right? So my rule of thumb is MTV, like the music television channel, MTV. The measles, tuberculosis, and varicella. Those are the three that we know are all part of that airborne. We do add in smallpox, but that's kind of been eradicated, so it's not a real big deal. and I'm still uncertain about coronavirus, COVID-19 specifically. We know that the mask has been effective, and we don't put people on isolation for airborne precautions, but still to date, they're still living with that. So teach your patients, although, avoid people who are immunocompromised, people who have not had chickenpox, you should stay away from them. The cool and warm compresses or showers will help. Wear loose clothing and don't scratch it and irritate it, and take the medications you need. Last, but certainly not least, is going to be immobility. Immobility is just the limitation of independent, purposeful physical movement of any part of the body or extremities, right? So you as a nurse have to be aware of some of the physiological changes and effects of prolonged immobility, right? The nurse has to be able to understand that laying in bed has a lot of adverse reactions, right? If you're laying there doing nothing, it puts you at risk for pressure, right? So pressure ulcers are a big thing. If you're not moving, you can also get respiratory secretions in your lungs, so pneumonia is a big thing. The muscles can start to atrophy, meaning they start to get weak or they start to get shortened and tighten up. You can get pressure ulcers, we know that. You can also get constipated, so it can cause GI issues as well. So these patients might need you to get them up and increase their water and their fiber and give them something to help get their bowels moving. You want to encourage these patients to do any kind of active motion they can, so some dorsal flexion exercises to reduce any kind of problems with, venous return in the legs. So that would help with your patients who have limited mobility. Make sure that their bed is not elevated over 30 degrees. If you have it too far up, they're going to slide down in the bed. We know if their back gets stuck to the back of the bed and they start to slide, it can cause shearing and rip skin off. Once again, I need you to start thinking about what your role as a nurse is. Grandma is in the hospital with you for 12 hours. My job is to make sure she gets no worse, but better. Place pillows or foam wedges between the bony surfaces, between the bed and the bony surfaces. We're trying to take that pressure off. Float their heels off the bed on a sturdy pillow, right? We want to offload some of the pressure that's over these bony prominences. We know it. We know it works. The science is there. So these are the things you need to focus on, and then think about their increased risk for falls. If you're immobile, we should probably put the patient closer to the nurse's station. We want to think about patients who are incontinent or confused or unable to communicate. They're always more likely to fall. So put a bedside commode close to the side of the bed. Put a bed alarm on. You can even get the ones where cameras are watching your patients. So all of these are great options, and this is where your mind needs to be when you're going through these chapters. All right, if you need anything at all, please let me know. Otherwise, have a great day.